My name is David Cornwell, and today I'm speaking with my friend and colleague Ray Baskerville, who works at a residential treatment facility for eating disorders in Hawaii. He's completing his doctoral research on the link between eating disorders and attachment theory. In our conversation, we explore how early relational experiences shape eating disorders, the realities of residential treatment, and the role of mindfulness and embodiment in recovery. My friend Ray Baskerville, and I would just like to begin by asking you, Ray, what was the journey that brought you into this work?
Well, my answer might be disappointing because I was looking for a job to get clinical hours and practice my skills, and I saw a job advertised at this facility and they hired me, and so that's really the long and tall of it.
Can you say a little bit about the facility? What is the nature of this facility?
Well, it's as you've said, residential treatment means 24/7, 7 days a week. And it's for women or women identifying only, because it's a small facility. We've got a maximum of 12 beds, so we would have a maximum of 12 patients at a time. Typically, it's lower than that, somewhere at 8, 9, something like that, maybe typically, or even less. And they're of all ages. The youngest we take, I believe, is 14. And the oldest in my time working there, I think, was 66.
Okay. And what is the average duration of their stay?
That's sort of changed over the time that I worked there. It used to be longer, or that's my recollection of it anyway. And sadly, the length of stay is very often dictated by their insurance coverage, because here in America, it's paid for by private medical insurance. So residential treatment care is expensive, and insurers prefer not to be paying for it if they can be paying for a lower level of care. So their criterion is often based on medical status and patients' weight, if in the case of anorexia, where they might be under ideal body weight. And they look at those kinds of markers more so than look at how advanced are they in their recovery and their healing. So typical stay, I would say 8 weeks-ish, something like that.
Okay. And so the 8-week stay will come to an end when one of the physicians or one of the specialists has said that this client is then safe to go home. Is that how it's decided?
Ideally, but rarely. So the insurers will pre-approve a certain amount of time. Maybe it's 14 days or something when they first come in. Sometimes not. Sometimes it is less. And then there's a weekly insurance review where a member of our staff talks to the insurer's reviewer about what's been going on with the patient, where they're making progress, where they're not making progress, what the challenges are, and so on. And based on that, and they also have access to the medical data that I talked about, they say, okay, we'll give you another week. We'll give you 5 more days. And at some point in that dialogue, those weekly insurance reviews, the insurer will start indicating that they're looking for a step-down date, right?
Okay,
or
wow.
Typically to move to a PHP, which stands for partial hospitalization, which usually is between a 7 or 10-hour day, most frequently 5 days a week, but sometimes 6 or 7. But not living there. So people at that level of care would be independent in the evenings and on the weekends if the program doesn't go to the weekends.
What are the main eating disorders that you treat? And could you give some classification of the different disorders?
Okay, I'll do my best. Well, the one most people will have heard of, which I mentioned already, is anorexia nervosa, which is a restrictive eating disorder where for a variety of different reasons, there's an inadequate intake of nutrition. Why somebody might be doing that, again, is multifaceted. But towards the surface, at least, there can be fears of weight gain, a desire for thinness, body dysmorphia, meaning their perception of themselves doesn't match the reality of what they actually look like. So somebody who is underweight might look at themselves in the mirror in a photograph and think that they're fat. And there are two types of anorexia. There's a restricting type, which I described just now, and purging type. So they might be restricting and purging. And we would also classify, for example, excessive exercising as a form of purging. Because it's with the intention to lose weight, to affect their body shape and size.
Okay. And then the other major disorders, I guess, bulimia is the next
Bulimia nervosa, which is characterized by using some means to expel consumed food from the body. So very typically that would be by making yourself vomit, but it also could be through the use of laxatives, say, and after eating, just in one of those two primary ways, expelling what's been eaten from the body before it can be digested.
Okay. And then is the third major type binging of eating disorder?
Typically we would say so, binge eating disorder, which is eating in excess of the body's need for nutrition. But actually, statistically, worldwide, there's a classification which covers a multitude of eating disorders that don't meet the criteria for anorexia diagnosis or bulimia diagnosis, and it's eating disorder not specified. And even though in treatment where I work, that's not the most common one to show up, according to international research, it's the most common eating disorder. So, and then there's another one, ARFID, which is where it's more a sensory kind of issue, and that can be quite common with people who are neurodivergent, for example.
Okay.
And not typically about concerns to manipulate the body weight or appearance, but it's more intense challenges around how food tastes, feels in the mouth, smells, all the sensory kind of issues.
Okay, so we have these major classifications. I guess the major ones are anorexia nervosa, bulimia nervosa, and binge eating. Which styles, or what do you normally treat at your facility? What would you see most commonly?
Most commonly anorexia. Yeah, most commonly anorexia. As I say, because medical criteria is a significant component in why people might need that level of care. They have to be assessed to need such a high level of care, and being underweight, insufficient nutrition intake are going to cause medical problems. So most commonly, But we also do have people with bulimia, binge eating disorder. I think we have people with all of the diagnoses, but predominantly anorexia.
Okay. Because anorexia is the most dangerous. Is that the reason why people are getting residential treatment for anorexia at your facility?
Yeah, anorexia has the second highest death rate next to opioid abuse.
Wow. Across the board, like with male and female, young people, old people?
Yeah. So death doesn't necessarily come from starvation, though it does. It can come from other medical issues that arise from being malnourished. Being malnourished can cause all kinds of heart problems. So people can have heart attacks, but suicide is also a big percentage of that death rate.
At the facility you're working in, what would a regular day's treatment look like for those patients?
A typical day is going to start by doing vitals first thing. So that would be blood pressure, things like that. And we have a nurse 24/7 in the facility, so they do that. Then they would have their first meal of the day. And so when they're sitting at the table, they would have we call a food and feelings sheet, where they have different spaces where they can know what they're doing, how they're feeling, noting any eating disorder thoughts, noting any healthy thoughts, recovery-minded thoughts as they're going through the process of eating. And they with usually 2 members of staff.
Each patient, or as a group?
No, at the table. At the table,
Okay.
There would be a minimum of 1, but often 2 members of staff. And very typically, they play table games as a way of kind of distracting, having something else, also to overcome for many people with eating disorders, there's embarrassment about eating in front of other people. Eating disorders tend to lead to isolating behavior, particularly at times of eating. So there can be a lot of sort of anxiety just being at the table eating in front of other people. So playing these kinds of table games, which are, it's a while since I've done table work, so I can't think of them, but just mental games of to help them be distracted, to be engaged with each other. And before the meal starts, they would do a check-in to help them tune into their hunger cues. And that's done on a scale of 1 to 10. And then at the end of the meal, there's
what are hunger cues? Can you elaborate on that?
Yeah, so it's assessing your level of hunger. Typically at breakfast, say, it's first meal of the day, no one's eaten, or most people haven't eaten since the previous evening. So hunger might be typically at a 3 or 4, something like that. And then at the end of the meal, they do a checkout, which is, again, giving them an opportunity to attune to their fullness cues. And a healthy fullness checkout would be something like a 7, maybe an 8. 9, 10, then you've probably eaten past what the natural fullness cue would have been. So again, depending on the eating disorder, there's difficulty identifying what those hunger cues are. And so every day at every meal, there's an opportunity to have to intentionally try and attune to those messages.
You and I, we both come from this mindfulness tradition, and something I was reading today that, eating disorder is very much connected to a sort of a dysfunctional sense of embodiment. So I don't know if you would agree with that, but I would guess that looking at these hunger cues and would start to reconnect someone and give them more of a sense of their embodied state in relation to eating.
Exactly. Yeah. There's a real disconnection for most people with eating disorders from the body, from bodily awareness, from interoception capacity to look inwards and notice and identify what's happening internally within the body system. So yeah, it's a way of inviting them to practice those skills, and so people say with anorexia, even though it's breakfast, they haven't eaten since the evening before, they might check in at a 10 because they think they don't need to eat and they can't perceive really what's going on in their body. They might perceive an emotional fullness, say, or even a numbness that doesn't allow them to identify what's actually going on. So they go with what they think. So I think I'm full. I think I don't need to eat. Therefore, I'm checking in at a 10 or a 9.
Okay.
Whereas in reality, that they're just disconnected from bodies, as you say.
Okay. And the goal at that first meal, is it to eat a certain amount of food? Like if somebody is refusing to eat or they're not eating, how do you progress that? Like what is the intention with every time you sit down to eat with the client?
Well, each patient has an individual meal plan which they work together with our dietitian once a week to sit down and plan for the week. And obviously the dietitian doesn't let them dictate, but it's to allow them some contribution to understanding why their meal plan is what it is. And they have a certain amount of changes they can make that's limited to how many they can make a week. And so how much is on their plate is going to be dictated by their meal plan, and that may be different for different people. Depending on where they are in their process of recovery, it might be that they have to eat everything, right? And there's a certain number of calories in each meal to make an amount for the day that they have to reach to hit their nutritional goals. And if they are unable or unwilling to eat the food, then they would be offered a liquid supplement.
Okay.
And they can decline that, there's no use of force in any of this. But certain things, so typically after breakfast, for example, they would go on a short beach walk. We're very near the ocean. And so they would have a mindful beach walk, but they can't go on that walk after breakfast if they've not been meal compliant, say the day before.
Okay.
And then on Thursdays and Saturdays, there are outings where they might go to a beach for a number of hours, or they might go to somewhere else in nature. And they need to be compliant for a certain number of days over the previous week to be able to go on those outings.
Do the patients at your facility, are they there voluntarily, or they're put there, or is it because their families are placing them there, or what? Because I find in my work that if someone doesn't want to be in a place, it's very difficult to help them. But also that can also be part of the person's process that, maybe they go to a residential facility, they don't want to be there, but that can be part of a longer process of them eventually being willing to be there and to engage more deeply in the process. But certainly if somebody comes to a facility and they don't want to be there, that can be more challenging to work with.
Right. So it's voluntary, except in the case of minors, right? So under 18. And very often they are the ones who don't want to be there, in part because, it's kind of weird as an adolescent to be away from home, living with a bunch of other women who you don't know, and all these things that level of care requires. But also, they might be very attached to their eating disorder, and unwilling to give it up because it's serving a purpose for them, which I'm sure we'll come on to talk about. So it tends to be more the minors, the adolescents who are entrenched in that resistance to being in treatment, and sometimes they don't get past that, and we have people returning because they weren't ready, they weren't developmentally ready sometimes too, psychologically, and they need a little more maturity, a little brain development to be able to actually fully engage and understand the challenge that their eating disorder brings for them, and find the desire to want to.
And okay, so to continue with the schedule, how many meals will they have a day?
They'll have 3 meals a day, and typically 2 snacks. So one snack would be at 3 p.m. in the afternoon. The other one would be in the evening. I think it's around 8 o'clock. There are a few people who might also have a morning snack, and they typically might be people who are trying to weight restore and it's not happening for whatever reason. Or it might be that they want to challenge themselves, right? They are really invested in recovery, and they voluntarily asked to do that additional snack.
What is the therapy schedule, and what types of therapy will they have?
Well, every patient has an individual therapist who they see 3 times a week.
Okay.
And they meet the dietitian, as I say, 1 time a week, and they have an intake assessment by a psychiatrist when they first come in. And then there are groups throughout the day. So typically after the beach walk, there'll be a group at 9:30. There'll be another group at 11. Then 12, they have lunch. They have some tech time where they get their phones and so on. After lunch for 30 minutes to an hour, depending on the schedule for the day. And then there'll be a group, say, at 2, another group at 4 after the afternoon snack. And then in the evening, it's more, for some, it's shower times and stuff. They might watch a movie together. It sort of slows down.
That's pretty intense as the therapy program. I've talked to people who've done residential programs, mostly in rehab, but some of them will not get any individual therapy, or will maybe get 1 individual therapy session, very limited. So it sounds like the treatment that you're given is pretty intense for the client, for the patient.
Yeah, the groups vary a lot though, so they're not all kind of group therapy type things. For example, we have somebody who comes in and does ukulele with them, and they do music, and there might be a horticulture group where they go outside in the garden and they're growing things, and there's an art therapy group. So there's quite a variety of different ways of engaging them as a whole person, not just, you've got an eating disorder, you're sick, and everything's focused on that. It's a more holistic approach to, the whole person rather than just their disorder.
What about embodiment practices like yoga or qigong or tai chi? Are these part of your program?
Yeah, they have a yoga group once a week, and I do an embodiment, which I just recently started. So yeah, twice a week they're doing body-based, non-cognitive kind of work.
What does that look like? And then what does an embodiment group session look like?
Well, I'm drawing on my past history as a dancer of a particular type, which we obviously don't need to talk about. But in that creative work, there was a lot of emphasis on introspection, on a real capacity to slow down and really notice what's happening in the body. So typically in that group, for example, if I think about this week, I did work with them. We do a lot of work around finding center, finding the gravitational center, finding vertical axis center through the body. And we do that with small movements of adjusting the weight distribution in a standing position. So noticing how that changes what's happening in the feet, in the knees, in the pelvis, and so on. And so in that way, using these small micro movements to again build that interoceptive awareness. And then I like on Monday, I had them identifying where their center of gravity was and then walking and exaggerating their walk to lead with that center of gravity. Mm-hmm. And then we switched around. So they had different centers of gravity. And so I had them walk in each other's, leading with each other's center of gravity to get a different sense of what that feels like and how that changes their perception of their own body and so on. And of course, for them, whatever their center of gravity, it just felt normal to walk that way. Somebody else's, it felt weird and unbalanced or whatever, So just these different ways of exploring what it is to inhabit a body, what it is to move through space in a body, but really with very micro movements and not a lot of exertion.
Okay. We talk, and there's research showing that people with reduced interoceptive awareness, like the simple capacity to feel what's happening in their body, to feel their breathing, to feel the movement of their belly or their whether they need to go to the bathroom or not, could be simple things. There is research showing that people with decreased interoceptive awareness are more likely to suffer from depression or anxiety disorders. And I'm wondering, do you see that in the clinic, that people are disconnected from their bodies, that there is a diminished capacity for interoceptive awareness or embodiment? Is that something that you would notice? And also, if you cultivate or develop their embodied awareness, that can be pretty transformative for the patient.
Yeah, and I would add into that too, disconnection from feelings, states, from emotions, because they are largely in the body. So, that might move us into why people have eating disorders. Very often because the eating disorder is a way of not feeling what's going on, not feeling the emotions, not feeling the bodily sensations that arise from particular memories and lived experiences, some of which they may not even remember. The eating disorder is a maladaptive way of coping with anxiety, other feelings. And I think depression can be as a consequence of that disconnection from one's own living emotional experience. So everything feels flat and gray, and or there's an oscillation dramatically between surges of emotion and anxiety, and then, the fall down into depressive state. So that also can be fairly common.
Okay. So let me ask, right, let's open up this subject of why, as you said, why people have eating disorders. But I'd like to look at it from your own sort of academic basis. You've wrote your doctoral thesis on eating disorders and attachment theory, attachment styles. And I guess a place to start would be to lay out the different attachment styles in the same way we laid out the different eating disorders. Where did the different attachment styles originate? What is attachment theory?
Okay. That's a vast subject, so
Yeah.
I'm going to keep it fairly simplified. So we could just start with, and again, this is a simplification, but we could say there are 4 primary attachment styles. Secure, which would result from in the early years of an infant's life, there being sufficient attunement, attention, coordination between the mother or the primary attachment figure and the infant. So she's attuned, responsive, and engaged with her baby. And ideally that is a pattern that continues through childhood. So again, I'm going to throw in a caveat here. So, for example, say the first year of life, that was the case. There was a very secure bond between mother and infant, and then something happens in the mother's life. Her mother dies, she gets depressed, or she gets sick and is less available, or she has to go back to work, all these kinds of things, or God forbid, she dies. Something that can alter that pattern and start to introduce a sense of insecurity, right? So we can talk in generalized terms, but the complexity of human experience means they're not really going to be accurate, but they're helpful as a sort of baseline understanding of the significance of attachment in our human lived experience, and what are the consequences when it's not secure. So the other 3 would be classified as different types of insecure attachment. So I'm going to use the original terms, so avoidant, ambivalent, and then the later one that was identified as disorganized. So avoidant comes from one, a lack of attunement, particularly emotionally, by the attachment figure, maybe a coldness, aloofness, a distance in the attachment figure. It could be there's a sort of harshness, an inability to non-verbally connect with the infant, and that consistently experience would lead to a shutting down of the attachment system and an avoidant attachment style. So an avoidance of the vulnerability of trying to connect, an avoidance of intimacy, a requirement of independence. Even in very young children, this is seen, and that's how it was identified.
Okay. When you say a shutting down of the attachment system, is that, like, for example, it makes me think of polyvagal theory and the social nervous system. So that quality of nervous system regulation through the ventral branch of the vagus nerve, that's able to find that tend and befriend sense of homeostasis, sense of safety. Is that what you mean with the shutting down of the, or could we understand the shutting down of the attachment system through that lens, or how would you
Yeah,
explain it?
no, I think that's certainly the case. But the original idea of Bowlby in his conceptualizing of attachment theory, and the many people who worked on it subsequently, Mary May, Mary Ainsworth, was that the drive to attachment is biological.
Okay.
It's a survival instinct that we have because as newborns, as even into, young childhood, we're utterly dependent. And when we're born, we're utterly helpless. So if we're not taken care of, if we don't create a relational bond to have our needs met, then potentially we're not going to survive. So
Okay.
it's survival driven, and that's why the implications of it not being secure are so profound and so deep in our psychological and
So
emotional systems.
it's a biological drive. So it's also experienced biologically. It's felt in the body.
On that point, it's felt in our body, I think is really important here, and again ties into what we've been talking about with the eating disorders and kind of lack of interoceptive perception. The first at least 2 years of our lives, everything we're experiencing is feelings, emotions, and body sensations, right? And there's no interpretation of them by our minds because we don't have language yet. And even as language develops, it's very limited, it's very simple, it lacks the complexity to be able to make sense of what we're feeling. And so if what we're feeling is insecure, is not safe, is rejected, is uncertain, is anxious, they're unpleasant feelings to have, right? And so we start to develop ways of managing those feelings. And in an avoidant attachment style, it is to not feel them, to disconnect from the body.
And, if when we experience difficulty in our lives as adults, it can be a very difficult experience, very unpleasant to be in the body. Your stomach is in knots. You feel like you're all tied up. You can't breathe. And I can imagine, at least we have the cognitive understanding maybe to connect our external experience with what we are experiencing in our body. But a pre-verbal, 1-year-old or 2-year-old baby isn't able to make that understanding or connection. And then I guess the experience of being in their body is equally difficult, and then they shut down, they don't feel safe, they begin to go into more defensive nervous system responses, and they go into a shutdown response and avoidance.
Exactly. Yeah. So yeah, those feeling states from those early years of life, they remain in the body, right? And as we grow older and there's a stacking of experiences that then become also interpretations of what those feelings mean. So this is where shame starts to play in, where we interpret those feelings as there's something wrong with me. I'm unlovable. And there's a requirement to keep that hidden. We start developing masking personas and presentations of self that we think will be acceptable. We socially withdraw and we avoid even any kind of exposure. So all of these things stack and build on top of those early life experiences.
Can we go through the other stats? We've got ambivalent and disorganized.
Surely. So ambivalent typically is a consequence of inconsistency in the attachment relationship. So in the simplest terms, sometimes the attachment figure, the mother, is available, is present, is attentive, and then not. And then back again, and then not. And so what that tends to lead to is a hyperactivation of the attachment system. because there's this constant fear, oh, mother's here now, I'm safe, but she could leave at any minute and then I'm going to be alone again. And so typically those kinds of infants would be the ones who are very emotionally dysregulated, often crying a lot, clinging, needy, anxious. So that's, in the broadest strokes, ambivalent attachment.
And disorganized?
And then disorganized. Yeah, disorganized is kind of its own category. And I see the spectrum. Let's introduce the idea of a spectrum for ambivalent and avoidant. And I see that spectrum as being a kind of trauma of deficit, a small t trauma. So it's not single events, but it's the accumulation of repeated experiences creating an emotional deficit. More than an emotional, sometimes, a biological needs deficit. So disorganized is more towards the territory of what we would call a big T trauma. So it occurs when the attachment...
Sorry, are you saying that avoidant and ambivalent are small T trauma, whereas disorganized is big T trauma?
It's more towards big T trauma, yeah.
Okay.
Yeah, in simple classification, we would say the difference is one is small t and the other big T.
Yeah.
So big T trauma is a trauma of overwhelm, right? Where the system's overwhelmed, we can process what we're experiencing. And in disorganized attachment, that occurs when the attachment bigger becomes a source of threat or danger.
Okay.
Either because they're angry, volatile, violent, hurting us, or on the opposite end of the scale, they suddenly are completely gone. Like if major depression set in, or, there's I remember having a client who experienced this when their mother's mother died, and all of a sudden, their mother was just in bed, so depressed, couldn't get out of bed, couldn't take care of them. And as a 4-year-old, I think maybe she's suddenly taking care of her younger siblings, right? So
funny, I had a very similar client. And also eating disorder related, similar thing.
Okay. Disorganized can occur even in secure attachment, right? Because it is more specific events. And if those events are accumulative, then we might classify that as developmental trauma.
Okay.
So disorganized can occur with secure, ambivalent, and avoidant attachment styles. And it's an exacerbating feature. It increases the likelihood of extremer expressions of those survival strategies.
Yeah.
People are more prone to other mental health diagnoses. Borderline personality, for example, there's a lot of very strong correlation with disorganized attachment.
From my understanding, Ray, from speaking with you before, there's some correlation between the eating disorder style that a person might have and their style of attachment. Is that correct?
Yeah, and again, people are very complex, so we can't just neatly pigeonhole these things, but there's a pretty strong correlation between an avoidant attachment style and restrictive eating behavior, so anorexia. And binge eating disorder more closely correlated to an ambivalent attachment style.
Okay.
And bulimia can go either way, but there's often some component of disorganized in there. The purging is a literal attempt to try and get feelings and emotions out of the body.
Can I ask you to flesh these out a little bit? So you have avoidance, the avoidant attachment style. There's a coldness, an aloofness, harshness in the relationship with the mother, and that can then manifest as restrictive eating, anorexia. Can you say more? Like, what would that look like?
Okay, yeah. So the avoidance is of feeling. It's an avoidance of connection, of intimacy. And when you put food in your body, then you become aware of your body. And the body is the place where we have our feelings and our emotions. So anorexia is an attempt to not feel, to be numb, to avoid contact with the feelings from childhood, which might be a sense of abandonment. It might be these threads of shame that I mentioned, of the interpretation that we later made of these early life feeling states. And as we were talking about earlier, there's this disconnection from the body. So there's a desire to not have a body, almost, to make the body as small as possible. And here, other components also start to play in, traumas that may have occurred later in life. For example, if there was some kind of sexual abuse or something of that nature where there's a violation of the body, then there might be a desire to make the body as small as possible so that it's as less visible, less noticeable, and therefore sacred. These are the cognitive patterns that accompany anorexia. So again, we're sort of moving into more of the complexity of things, but typically it's that, is I don't want to feel, and putting food in my body makes me feel. And then there's all the layers of...
How does putting food in your body make you feel something? Just help me understand that. It's probably a very simple piece and it's very obvious, but it seems an important piece. Is it because the literal feeling of having your belly fill up?
Literally. Yeah, literally.
Somebody who's got an avoidant attachment style, they simply don't want to have that interoceptive feeling, that reminder that they have a body. Because when they go to the body, it's a place of, it's not a safe place, it's a place of fear, it's a place of overwhelm. Is that correct?
Yeah, pretty much. Like I say, there's all these layers on top. So typically they've been praised for being in a smaller body because it's socially desirable. And so then there's that layer in adolescence. Oh, I get attention in a positive way for being in this small body. And so that becomes another factor. And then there's a fear of, oh, if I gain weight and I'm in a bigger body, I will lose that positive attention, which is craved, right? Because of the insecurity. And so feeling full feels like danger. It feels like a threat to that objective.
So when you're working with someone who has this avoidant attachment style, maybe is anorexic, what would be the intervention that you would do to support that person to heal? Is there a mindfulness-based intervention that you would use?
It's all different ways of approaching developing interoception, developing what we would call affect tolerance, the capacity to have feelings and feel okay, not be overwhelmed by them. So typically with anorexia, that tends to be a slower kind of process, depending on the degree of disconnection that they have from their body and their emotions. Say they're coming to session and they're distressed about a meal that they had earlier that day or the day before something. Then I might, after empathically responding to their distress, which can be sometimes quite extreme, it can be quite dysregulated over, I got too much of this on my plate and I shouldn't have had, or they made this mistake with my meal, or I don't believe I should be having to eat this much kind of stuff. I would be working with those arising emotions, those presenting emotions, and helping them to develop skills to create containment for them, which is where, the mindfulness might come in. I might invite them to, say, I typically work outside, living in Hawaii, again, to attune to the sounds of birds around, right? So they're expanding their awareness into a wider field, and then the concentration of feeling in their bodies and this distress now has a counterpoint, and it's also, we're developing a wider container for it. And so slowly, by introducing other things that they can simultaneously be aware of, they start to experience, I can have these big feelings and emotions and I can actually be okay. And through consistent practice of those kinds of things in individual sessions, they start to develop that capacity for themselves. And then it might also go backwards in time. So let's remember what it was like at the table, right? What were the feelings that came up for you then? And a similar kind of process with those feelings. So process of making what was previously intolerable tolerable through the practice of mindfulness, the application of mindfulness, and creating that container, dual awareness, all of those kinds of things.
You said that there's a relationship between ambivalent attachment and binge eating.
Yeah. So ambivalent attachment is sort of, you can't turn off or tone down the emotions. They just flood and overwhelm. And what's the driver there? The driver there is to find and arrive at a sense of connection, safety, security, comfort. And so binge eating can follow that same kind of pattern where there's an inability to stop, because emotionally what's driving is this pursuit of a sense of comfort, of ease, of having one's needs met, and their emotional needs that are being attempted to be met by food.
Okay. And then disorganized and bulimia?
Bulimia, yeah. So as I mentioned earlier, the act of expelling the food, of making yourself vomit, very often comes from those trauma states resonating in the body, maybe becoming aware of them because of having eaten, and an attempt to expel them. And very often people with bulimia they report that there's a brief moment of euphoria after they've thrown up. There's a brief moment of being at peace, of rise from the stress and anxiety that they live with. Also, then you've got the layers of it being driven by, I don't want to gain weight, I want to be in a smaller body, and all the social conditioning that
Yeah.
that exists around them.
But would you see that bulimia is often connected with, I think you said this earlier, big T traumas, so be events, maybe abuse, maybe growing up in a very chaotic environment. There's a connection between bulimia and having experienced overwhelming experiences, traumatic experiences.
Yeah, yeah. And, bulimia, again, this is very broad brushstrokes. This is not always going to be
Yeah.
the case. People are complex. It's more likely to be a combination of ambivalent attachment and disorganized. And in anorexia, if it's a purging type, then it's more likely to be an avoidant attachment and disorganized.
Okay.
And again, that's not always going to be true, not always going to be the case.
And Ray, I'm assuming they also overlap, because I have worked with clients who both are bulimic and binging, right? So that's, and also with anorexia, you see anorexic who purge, or who, I think you said the classification was who restrict or who purge. So it's a very complex picture. People can have traits of these different styles at different times.
Yes. And that can be, they learn new behaviors in treatment. As a teenager, as a restricting anorexic, and they learn from other people there, oh, you can also do this. You can make yourself purge, and so in the same way that we can't hold attachment styles as rigid things that always manifest in all circumstances, in all conditions. Our attachment styles are survival adaptation, so they are going to show up in different ways depending on the circumstances we're in. Eating disorders are a maladaptive way of attempting to navigate the stress, anxiety, and these deeper attachment wounds, maybe other, big T traumas. And so they're going to show up in different ways and depending on a person's life circumstances.
So these insecure attachment styles, let's say they're an attempt to feel safe. Can someone heal? Can they feel secure if they've had this early developmental period and these insecure attachment styles have become their pattern? Is it possible for them in later life to feel secure?
Yeah, it definitely is. That's called an earned security.
Okay.
Put myself in that classification. And again, this is where, for me, mindfulness is so applicable and so powerful. So the first thing to say is, you can get an earned security, and that's probably going to take a good amount of time, and it's going to be a lot of work. So going back to mindfulness, I see the practice of mindfulness, and I teach a mindfulness group at iPorno. I see it fundamentally as a practice through which we develop a new way of being in relationship with ourselves, where we learn to be present and accepting of all of ourselves. And ultimately, we meet all of ourselves with kindness and compassion. That's sort of the intent. And the practice is, well, how do we do that? And how do I try and do that a little better tomorrow? Or, so the intention to pay attention to your own experience as it arises with an attitude of curious kindness. That's sort of my brief summation of what we're doing in practicing mindfulness. So I see there are two dimensions to the healing of insecure attachment. One is that internal relationship with ourselves, which is where mindfulness can be so helpful, because we accumulate brain changes through neuroplasticity through the practice, there's supposedly some research that demonstrates that the areas of our brain that are active when we're practicing mindfulness, paying attention intentionally, are the same areas of our brain that would indicate us having a secure attachment, that would develop with secure attachment.
Oh, wow.
So there's some ways in which insecure attachment is also neurological, because certain areas of our brain didn't get the experiences necessary frequently enough to really develop, right? The brain develops through what we experience and what we do with it. So practicing mindfulness is an opportunity to regain that. Again, from my own experience, it's not enough on its own, because we aren't going to meet necessarily all of ourselves sitting on the cushion. So the external dimension is also important. So healing through relationship with another. Can we find the trust in ourselves to stay present in relationship with another, to be vulnerable, to allow connection, to be seen for an avoidant, to be to find reliability in another for an ambivalent, say. And so through these two dimensions, utilizing skills in both, we can create a secure attachment for ourselves and earn security.
Okay. I can second that. My experience is very similar. One thing that I've noticed working with clients, eating disorder clients, is that, you know, there can be these moments. You described one earlier when you said, you know, the moment following someone purging, there can be an experience of euphoria. Well, in the same way, in the moment before they restrict, or the moment before they, you know, they sort of strengthen their eating disorder behavior, whatever it might be. You know, I'm thinking of people who they look in the mirror and they see themselves as overweight, or they have body dysmorphia, or they feel a lot of shame in that moment, or when they think of how their body looks, or when they think of themselves in public, at the beach, or whatever it might be. If they, in that moment, can pay attention to their inner experience, they can feel that it's very strongly unpleasant, perhaps, like it's a sensory process, an emotional process. They can experience that the body's tightened, or that there's a discomfort. It's visceral. And they can also make the connection then to the thought pattern that is emerging, you know, this, and the thought might be, I look terrible. And then that drives the next moment of behavior, you know, the person then not eating, or, you know, not going to the beach, or whatever it might be. And I think that that's what is happening for all of us all of the time. But with eating disorder, people with eating disorders, if they can catch that, if they can start to become aware of that process that is emerging all the time, and the connection between the embodied experience, the unpleasant experience, the difficult, very familiar thought processes, and the behaviors, the eating disorder behaviors, if they can see that very clearly, understand it, feel it, they can start to work on it. I'm not saying it's easy. I think it's very difficult, and maybe they need to start to develop some practice, and they need therapy. But I find that that's just having that awareness. I notice that when I'm working with eating disorder clients, that part of my work, and I'm working very much in an embodied way within a team of therapists, is really to help them to see that there is this pattern or this emerging process. And once they can see it, they can start to work on it. But I think it's very difficult, but nonetheless, there is value in that. What do you think of that?
Yeah, no, I think that's accurate. And cognitively, there's a very strong tendency to just black and white thinking. It's this or that. It's all or nothing. And so part of what you're describing is sort of finding the space between, right, where it's yes and something else might be possible.
Yeah,
Or
I feel it's difficult. I can notice the thought. I can even see the tendency to behave in a certain way. But in noticing that, now I have an option to do something different, even though that can be very difficult.
Yeah, I think one thing we haven't really touched on, which is also significant, is control.
Okay.
And that shows up again differently in the different eating disorders. So for anorexics, people with anorexia, I should say, they have a lot of pride often in their capacity to control their hunger. Right? It's a real source. They feel they have discipline, and so it's egocentric in that way. They feel good about themselves by doing this thing that is actually harming them. And so starting to eat and having feelings starts to feel like being out of control, right? Feelings, I can't control the feelings. And so what you're saying is the intervention of mindfulness, of stopping that thought from just following its normal cognitive pattern and going, you can just feel the feeling and you can notice the impulse that it gives rise to and so on. And with bulimia and binge eating, it's more the opposite. It's an inability to control. So there's a feeling, an internal feeling of being out of control, and that manifests in the behavior, the binging, I can't stop eating, bulimia, I have to go and purge this food out because I can't control the feelings that it's creating. So that's another significant thread that is a challenge for those with eating disorders. And again, I think where mindfulness is very applicable in, as you describe, noticing the feeling, noticing the impulse and the belief, the thought that arises from it, and then making a different choice.
I want to ask some questions which I have received from some people online. This is a question maybe we've already addressed, but can binge eating function as a form of emotional self-protection or self-soothing?
Yeah, absolutely. And that protection, again, if we want to expand things a little bit, and I hope it's okay to keep bringing up sexual assault, sexual abuse, there's the opposite protection there. Like we spoke about anorexics getting smaller to be less visible, to not be noticed. And they're not, again, it's just a maybe sometimes. In binge eating, it's to be unattractive. It is to be in a bigger body so that I won't get that attention. So I'll be left alone and I can feel safe in that way. So that's another component to it.
Okay. And I guess, is there, when someone is binging, yeah, I guess there's a soothing piece of it. It feels good in the moment.
That's what's being sought. I don't know that's what they find.
That's interesting.
Because it's almost never enough. It's that you never quite get there. You're getting close to it. It sort of feels like it in the moment, but then as soon as you stop eating, then it's gone again.
The next question: how can we know whether we are eating out of genuine need or if our food choices are due to emotional eating?
I guess pay attention to yourself, really.
Yeah.
what's driving the desire for that type of food in that moment. And I mean, we all do this, right? An eating disorder is where things that many of us might do normally, like we get anxious and we lose our appetite, so we don't eat. That can happen for many of us, or we're feeling anxious, and so we want some kind of comfort food, and we've all got our own comfort food. So it's not necessarily that there's something wrong with that, unless it becomes something that's happening really regularly. But again, it's like paying attention. And if you pay attention, you have that capacity to make a choice or not. Like, yeah, I want this ice cream because I had a really hard day and I want something cool and soothing and yummy. That's emotional eating. That's okay in my book, right? So doing it consciously, intentionally, even if it is emotional eating, is different from doing it as emotional eating, but not being aware that that's what's happening.
Okay. And, that brings me on to the next question, which is what makes eating behavior a disorder rather than just someone's natural eating habits? This is a question I have. I know from working with eating disorder clients, the clients are encouraged to eat 3 meals a day. But personally, I never eat breakfast. I only eat lunch, sometimes only a big lunch and then a very light dinner. Like what is the behavior that defines an eating disorder? What makes it disordered rather than personal preferences? You see nowadays, and I think it is a fine line. I see a lot of people doing intermittent fasting and things. So they've been able to place maybe their eating disorder within an acceptable context. Sometimes I wonder, but it's a fine line between disordered eating and people's individual preferences.
Yeah, I mean, I think in the simplest terms, it's because in an eating disorder, it causes distress.
Okay.
Right? It's driven by distress. There's another eating disorder which isn't in the DSM, so it's not going to be on the kind of clinical radar, but it's very common, which is orthorexia, which is where we, in the guise maybe of healthy eating, we won't eat this because it's got whatever in it that we deem to be unhealthy. And again, with that, there's a balance between, well, everybody's body is slightly different or significantly different. And what works for one person wouldn't work for other people. Like, for me, if I was eating the way you were eating, that wouldn't work for me. Like, my metabolism is different. I need consistent fuel in because that's just how my body works. So I think, are you preoccupied with thinking about it, with planning it? Does that cause anxiety? Does that cause distress? There's a line between, neurosis and pathology. So it's all in that kind of territory. And because food is so fundamental, I think most of us have some kind of thing going on with food. Like, we all have different kinds of things going on with money, say, or with sexuality. It's part of our
human experience.
Exactly, yeah.
Okay, can you ever fully get rid of an eating disorder?
Yeah, I believe so. Mm-hmm.
Say more, because I'm curious about that one also.
Okay, so...
Okay, just to bring in your last definition, which was a disorder is when somebody is distressed by food, or there's maybe a lot of energy, a lot of overthinking. It's an orientation point in their day that creates stress and preoccupation.
Mm-hmm.
And they're unhealthily over or underweight or binging or all of those parts. I guess if you're saying someone could get rid of this is the question, the language of the question, get rid of an eating disorder or heal from an eating disorder, that may look like that preoccupation is gone. They're not eating a balanced diet. They're not in they're not in an unhealthy place, and food is not taking up sort of excess real estate in their minds. Is that possible with eating disorder? Like, can someone really grow out of it?
Yeah, I would say definitely.
Okay.
And, again, I think it's helpful to think of things on a spectrum. And, we haven't talked about mindful eating or intuitive eating, but those are things that sort of wouldn't really be practiced at the level of care that I work at. They would come at lower levels of care, but with that attunement to your own body and your own body's rhythm needs, then where you start eating to meet those biological needs rather than all this other psycho-emotional stuff, then I think that's recovery.
So I have a couple more questions just to finish, Ray. One is, okay, so, you and I, we both work in residential facilities, and that level of care is very expensive. But it's, if you're lucky enough that you can get it, it can be very transformative. If somebody, let's say maybe their case is not requiring hospitalization or residential treatment, but they have an eating disorder, what kind of resources would you recommend they gather around themselves to help them work on it?
I would recommend getting a therapist who's familiar with eating disorders and a dietitian. In the United States, there's a difference between dietitian and nutritionist.
Okay.
The dietitian has gone through years of training, including medical training. They're not just focused on, what foods do what for you and that kind of thing. And that would be the place to start, I would suggest. And, maybe the person is really struggling and they would then refer to an appropriate level of care. Because in the struggle, it's become normal. So we the person might not think it's as bad as it really is. And then there's the hard choice of where to go for treatment. And again, that can be location. In the US, it's going to be insurance coverage. And in America, so many of the treatment facilities have been bought up by large corporations, and they're just big cookie cutter kind of places where they're just doing formulaic CBT or whatever. And I've heard of some terrible experiences that people have had, and shocking the things that are going on at some treatment facilities. So, it's really worth, if that is required. We're talking about residential PHP, IOP. You're probably going to be looking in your local proximity, your local, what's available in where you live or around where you live. But then again, a lot of things they're virtual now. You can do virtual IOPs, some virtual PHPs, but at IOP, I think it's probably okay. PHP, I think it's better to be in person somewhere.
So, Ray, I'll just say thank you for being so generous with your time. It's great to hear what you're doing and to get access to your experience. So thank you very much, Ray.
Yeah, I hope it's helpful to someone out there. Yeah. And again, people are very complex, so we can't just neatly pigeonhole these things, but there's a pretty strong correlation between an avoidant attachment style and restrictive eating behavior, so anorexia.